Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach here, close to the beach, about a mile away. Today we have the initial webcast of the Walter Dandy Saudi Arabia Club run by B.M. Saidu, a fifth-year medical student from Saudi, and she's going to be running the proceedings. Welcome, Dr. Saidu.
Thank you so much, Dr. June, for the introduction. And hello, everyone. I hope you're having a wonderful day so far. My name is Payam Sido, and I'm a final year medical student at Al Faisal University in Saudi Arabia. I'm joined here with my co-host, Amin Sido. She's going to be taking over and introducing Dr. Orkhan.
Hello, everyone. I hope you're having a wonderful day so far. My name is Amin, a member of the Walter E. Dandy Neurosurgical Society, a Saudi Arabia chapter. And I'm joined here with my colleague, Bayam Saido, the founder and president of our society. Thank you all for joining us today, and a huge thanks to Neurosurgical TV for their continuous support in making these educational sessions possible. It is our pleasure to introduce Dr. Orkhan Mammadkhanli, an honored neurosurgeon with extensive experience in complex spinal surgery, neuro-oncology, and functional neurosurgery. He is a fellow of the European and Turkish boards of neurosurgery and currently is a consultant neurosurgeon at the Pearl International Hospital in Qatar. With that said, let's begin our session. Dr. Mammadkhanli, the floor is yours.
Thank you very much. Thank you so much. Sorry, I will share. Can you see my screen?
Yes.
Yes, we can.
It's not full screen yet.
I try to do full screen. Okay, now can you see?
Perfect.
Perfect. Okay. Hi, good evening. Hi, everyone. Thank you very much for this invitation, Mr. John Bennett, and thank you for organization, Miss Biam and Miss Biam. So today we will speak about the percutaneous cement augmentation. So basically, for the treatment of the vertebral fracture, we have to percutaneous cement augmentation. There are two ways. Firstly, it's direct injection of the cement. It's vertebroplasty, and in second way, sometimes when our aim also restoring the height is kyphoplasty. First, we're putting a balloon, screw the working cannula, and after inflating, creating space and filling with cement. So, what's our indications? Indications is most of indication for cerebral cement augmentations related with vertebral compression fractures, mostly osteoporotic fractures, aggressive hemangioma, and it's minimally invasive treatment, effective in pain relief. In most of cases, also kyphoplasty can restore the height, especially in the more than 30% of loss of bone height. So contraindications here, mainly contraindication is destruction of posterior spinal elements, also retropulsion of bone fragments into spinal canal, and some of systemic contraindications such as uncorrectable coagulopathies and cement or contrast allergies. So also we have few debates about this topic. Is it better to do unilateral by one way or bilateral, or which type of fracture better? How much cement volume we need to fill, how much levels, and what should we do in special conditions such as ankylosing spondylitis? Also, which cement use, polymethyl methacrylate or calcium phosphate? So, appropriately, we need to evaluate patient correctly. Our diagnosis should be correct. Also, we shouldn't ignore the posterior wall, and we shouldn't underestimate the pedicle size. So, appropriately, first, of course, we check with X-ray. Here you can see the wedge fracture in L15434, L1 vertebra, lumbar one. And when we check with MRI on the T1, which sees a low signal intensity, which was showing us a bone marrow edema. Also, when we compare with same MRI with stir sequence, we see the high signal intensity, which one show us bone marrow edema, and it's showing us that this fracture is acute fracture. It's not chronic, so it will be better for this patient. Also, of course, in CT we evaluate this patient, and here I just want to show the postoperative feeling. So, commonly we use treatment in A1, A2, and A3, especially in wedge fractures, but we should especially contraindicated in the retropulsed bone fragments, significant posterior wall compromise, and if the patient have a neurological deficit. So here, one of the study of Cianfone and friends, which showing treatment of the split fractures or classified by our AO spine like A2. They're putting stent screw assisted internal fixation and after filling with cement and showing that it's good in this type of fracture. Also, it's one of the our case. This patient come as also L1 compression fracture. We evaluate and shows that this patient actually has so much systemic comorbidities. So we try to treat this patient minimal invasive way. When we evaluate, we show that this bone is not sclerotic. It means that it can expand. So in OT, when we gently hyperextend the patient, we saw that bone a little bit expand. And after bone expanding, we're putting the balloon and after feeling carefully. Because if there will over feeling, we can cause end plate fracture. So it's good field, it's postoperative X-ray of the patient. So in special conditions such as ankylosing spondylitis generally it's involve all three spinal columns, typically through their hyperextension mechanisms. It's better to fixate by screw, but if the patient need to do vertebroplasty, better use low volumes and extrapedicular access. How we starting planning the surgery? Planning surgery, we starting, of course, evaluating the axial CT image, which one show us real height and direction of the pedicle. Because fluoroscopy, which one we're using in the surgery, due to can enter us too medially or too laterally. If we're going too medially, we can breach the pedicle and go to spinal canal, or it can go too laterally. For example, in this patient, we can compare both pedicles. Of course, right pedicle it's thinner and sclerotic. Better here use left side. Also, we need to use for way selection. If narrower than 3 or 4 millimeter, it's better. Especially we need you maybe use extrapedicular or costotransversal way, especially in thoracic vertebra. And we need carefully evaluate venous anatomy. So we have basivertebral vein, and this vein, root of this vein, it acts as cement escape routes if pressure high or cement viscosity is low. So it's, for example, in OT, it's better to use biplanar. But for example, in our OT, we haven't biplanar fluoroscopy. That's why we changing real time. First in AP, after AP and lateral, we're using both together, like in worldwide. So also which way we can use, for example, anterolateral way, it's for cervical spine. Transpedicular most commonly using for the lumbar spine. Extrapedicular much more using for the thoracic spine. So technique basically like this. It's starting, it should be 1 centimeter superior and 1 centimeter lateral, and starting from the 11 o'clock and aiming 2 o'clock. If on AP we see that our Jamshid in here, so on lateral we should see this. Or for example, if see in the middle of pedicle, on the lateral we should confirm that we are middle of pedicle. And same if we're coming to the medial border, it should be on the junction of pedicle and corpus. So it's showing that we are correct place. And here another demonstration. Sorry. So also one of the problems, it's needle trajectory. So needle trajectory should start from pedicle and should aim more inferior and more anterior part of the vertebral corpus. So also it's mandatory to take a biopsy because some of patients has multiple myeloma. So we need in every patient before doing, not every patient, it's actually compression fractures. Some of patients also has multiple myeloma, and for the putting diagnosis, confirming, we need a biopsy. So, so which one better? Unilateral approach or bilateral procedures? So many studies, prospective studies, also another studies which one comparing and showing that actually in the long term, the no statistically significant difference between these ways. That's why better for the radiation exposure and less volume usage and shorter operative times, better unilateral and better to use a little bit oblique. I will show you in the next slide. But bilateral procedures considered when cement fails cross the midline after unilateral injection, and when symmetric distribution is not achieved, improve overall stability and cement spread. And sometimes in complex and centrally located defects. So also cement viscosity is also a big issue. So which one and content? Which content better use? Polymethyl methacrylate or calcium phosphate? So normally when we give polymethyl methacrylate inside of the vertebral body, it's starting heating, and after heating, yes, it's causing pain relief, thermal effect, and also it's killing osteoblast. So in the long term, there is no any fusion or growth, bone ingrowth. But in calcium phosphate, it's showing that a low bone ingrowth and remodeling, and it's resorbable. So if we need stiffness, it's better to use, especially for malignant lesion, polymethyl methacrylate, and it's when we need long-time durability. But when we use in younger patient, when it's need for the remodeling, it's better to use calcium phosphate. Here's the comparing according to biocompatibility, bioabsorption, and cement injection. So before we told that we shouldn't use low viscosity, but there are some pitfalls. So if we're giving early, there risk of leakage because low viscosity. If we're giving too late, there may be poor feeling. When we're doing overpressure, there's a chance of embolism. So also time, because I put here in slides that working time is from 5 to 8 minutes, but it also depends on the OT temperature and also which one polymethyl methacrylate you use, because maybe different brands, different time. And in cement injection, it's mandatory continuous fluoroscopy and especially mandatory stop in the when we have first leakage sign, and we shouldn't force. No need to over inject, especially in thoracic. We use maximum 3 cc, in the lumbar 5-7 cc. We need to use viscose cement and start in anterior third and stop when cement reaches posterior third. And better do like eggshell. So about cement volume. Firstly, about this, as I remember, in 2006 in Spine journal, Isadore Limberman showed his series that 1.5 million is enough for the pain relief. But now one of the last research in 2021 shows that ideally 5 million is enough, optimal for vertebral body size and distribution, and also it's ideal for adjacent segment protection. So also in this surgery we can have cement complication like cement leakage. It can be intravascular, go to venous, epidural. Epidural, it's for us maybe problem because it can go to spinal canal and cause paraplegia, discal, neurological deficit, pulmonary embolism, or infection. So here in our one patient in surgery, after surgery, I realized that here was a little bit fracture here in inferior end plate. So here was intradiscal leakage. So most of patients actually they don't know about the symptoms. Most of them like radiological sign, but in the long term, it can cause disc degeneration. Yes, here already a little bit degenerated, but can increase normal. So how much many number of levels we should do? Normally, most of authors recommended limiting augmentation up to 3 vertebral levels. Why? To the reduce of risk of complication such as cement leakage, thermal injury, systemic reaction, because some of authors reported that in their patients they have problem with the liver problems or systemic allergies. Also, one of the studies from Turkey shows that after 6 levels, or starting from the 7 levels, they're increasing the number of the pulmonary embolism. Some studies divided to up to 3 and more than 3, and showing that it's safe extension up to 5 or 6 level, but it depends on the experience of the center. Here's another studies. So what should be our takeaway message? First, we need to respect posterior wall. We shouldn't rush, because the safety, the patient is superior. In every case, we need to take a biopsy. Also, we shouldn't forget about the systemic treatment of osteoporosis for osteoporotic fractures. And thank you for listening.
Thank you so much, Dr. Mammadkhanli. This was an amazing lecture. We really appreciate your time. Does anyone of the audience have any questions? Either drop it in the chat box, or if you want, unmute yourself and let's see.
Students tend to stay shy, Pam. But
Yeah,
don't be shy. This is a small webcast. It's an intimate webcast, and you can ask Orkhan any questions you'd like. Well, I can see that worked.
Yeah, it means or they understand everything or they did not understand anything. If no
Okay.
any question, or everyone understand everything, or no one understands something.
Well, I don't know if you like, if you want to put your email in the chat, you can have people
Okay.
write. If you want to do that, just put in the chat. If anybody has questions, they can write directly to the source.
Yes, you're right. I'm talking.
Pam, it's a friendly community, and you're not going to get anything unless you ask.
definitely.
Neurosurgeons love to help your students. And any chance you give them, they'll help you. But you gotta give them a chance.
Yeah. Dr. Mammadkhanli, I have a question. Is there a role in cement augmentation in traumatic burst fractures if the patient has no neurological deficits?
Beautifully.
So I was asking if there's a role in cement augmentation in traumatic burst fractures if the patient does not have any neurological deficits.
So most of surgeons actually in burst fractures, if they I would say we need also understand the age of patients, systemic conditions. If there we need to do cement augmentation, we can, for example, give high viscosity and give slowly to the anterior cortex. And we need to evaluate how to say about posterior element of the corpus. But here I have a normal model. I just want to show you. And what about the condition of the posterior wall and how it's related with anterior? If possible, even a little bit volume enough for the pain relieving, because most of patients suffer from the pain. But it's so general question. Every patient is unique, is
Yeah.
different. But in burst fracture, because there are two burst fractures, A3, unstable burst fracture, and we have A4. In most of A3 patient is we're doing vertebroplasty. We can do it.
Okay, thank you so much.
Okay, there's a couple of questions
Mhm.
in the chat. Do you face venous or extravasation of cement?
Yes, I faced, but fortunately, it was just a paravertebral vein, and when we saw it, we directly stopped. So it's not going away. It's not, and there wasn't any pulmonary problem. Yes, I faced it. We directly stopped procedure.
Okay, what's
And
the
also,
worst?
it's wasn't on the 6th. And if we stopped before, it shouldn't. It wasn't be.
Okay, another question. What's the worst case you face for a learning point? I don't know what that means either. Do you know what
Really,
that
I
means,
also
Pam? Pam, do you know what that means?
I think he is asking what the worst case you faced is that taught you a lot, or like from a learning point. I think that's what he means. I'm not sure.
No, sometimes we learn from our mistakes. Sometimes we learn from another neurosurgeon mistakes. But I just read about the complications. So actually, thanks to God, I did not face like this complication. Yes, I have a little leakage to venous intradiscal, but there wasn't worse, such a epidural or which one we need to open. But I just heard from my colleagues who faced it.
Well, I'm not a neurosurgeon, but I know that you're faced with learning a lot of things like AI besides neurosurgery. How the heck do you guys find time to do that? Are you trying to keep up a little bit with AI and the new technologies, or you just don't have the time?
Here, I haven't actually.
Oh, yeah. Okay. Okay.
No, but I really wanted to learn, but in our environment we haven't.
Yeah.
But what do you mean, especially about the AI?
Well, just
Yani,
learning about it,
neural-
learning the basic tools. I find it's an excellent research tool, just like Google was, but a lot better, right?
No,
Right,
no, no.
Pam?
For research, I'm using, but
Yeah, that's
basically
what I
for
mean, because that's
no,
an
no, for
excellent.
research, I'm using every instrument which I have. But about in our previous university, we use so much about the AI as we can. But about this techniques, better I'm just learning on the cadaver.
Okay. Well,
But
let me,
better, for example, better, for example, in these cases, also use spine navigation. It's at least reduce the number of, but not in the cerebral, in the vertebroplasty, but better for the spine fixation.
yeah, I'm surprised that some of the answers are so specific and so deep, and you continue the conversation with the computer, and you can go in any direction you want. I'm very impressed with it as a research tool. What do you think, Pam?
I totally agree with you, honestly. It's really detailed. It's giving me neurosurgery knowledge in a very simplified way, simplifying concepts, simplifying different things. AI is amazing.
It
Really,
even leads the conversation. It'll say, don't you want to ask this? Or do you want me to do that? It expands the conversation in a very intelligent way.
yeah, it's impressive, honestly.
Yeah, it is.
But we need to filter which one AI response are.
Just regular chat GTP, start a conversation and just follow it. Just follow it. You could, the cementing you were talking about, you can start a chat with chat GTP and continue the conversation and take it
No,
name.
what I mean, first now ChatGPT a little bit changed. But before, when I'm using the ChatGPT, for example, I using the please give me citation about this topic. Which one, for example, 3 levels better or 6 levels? It look like this. It's finding first author from here, second author from here, number of the research from another place, and just fusion. Yet he giving you a response, but it's not correct. When you checking this reference, its reference not correct. But now maybe algorithm of the ChatGPT is changed.
I was gonna say, let's do a test run. Can you think of a question, Pam, that we can ask chat GTP and kind of show what it can do?
Tell us more about neurosurgical TV with references.
No, talk about the topic, cementing. Ask a question to chat GTP about cementing, about the topic.
What do you want me to ask?
Yeah, I'll try to get one too. Let's give us a second, Doc. Just one second.
Can I thank you, Dr. Orkhan, for this interesting topic. We enjoy very much.
Thank you very
Bone
much.
cement augmentation and minimal invasive surgery is a game changing. I want to add one point. Physician using AI will replace physician don't use AI very soon. It will make your life very easy, reviewing neurosurgery, even technique, everything. But at the end, nobody will replace human factors. But people and physicians investing sometimes a little time to learn a new AI tool, which is many of them totally free. And even we have a special website by Dr. Cohen from US for neurosurgery. It gives you almost in 30 seconds, will give you all indication, all approach, even the answer of your question if you're doing review for exam or anything. I recommend all resident and young colleague in neurosurgery to use this neurosurgical website for Dr. Cohen. And also we use AI in many cases. Before we are planning for surgery for tomorrow or reviewing even case, if I have a case in the clinic, I just put a small note for AI, give me summary, very professional for clinical note for 57 years old male presenting with this and this and this and this, and we plan for this. He give you full assessment, subjective, objective assessment plan. And sometimes you find some area is a way of your mind coming across to you, and you can just tailor a plan and tailor a piece of art of short summary in less than 3 minutes. So you can review, as you know, in your surgical practice, sometimes you face a busy clinic for 3 days or 4 days a week and 3 days for theater. So you have to put a quick note with a full assessment and a further plan. AI will make your life easy and you will live without this stress about caring of long typing or formulate and even adjusting report for the patient, and that's it. It lead to very game changing in this practice. And thank you very much for Dr. Jan Bennett, BMC Do, and her colleague for this interesting topic.
Mohammed, it sounds like you have a good understanding of AI and how to integrate it into your practice.
No. I'm just still learning. I'm
Well, we all
new
are.
surgery from 2012, but I'm still learning.
Yeah.
And as you know, it is innovation. Every year you face new things, new steps, new programs. Hopefully, one of us will have his own AI project for neurosurgery too.
Yeah.
Even you can use AI to make your own programs, or vice versa.
I do it a lot in getting speakers for the program for neurosurgical TV. If I have an area of neurosurgery I want to explore, it's a very helpful tool to find out neurosurgeons that are doing questions about what you're asking. Do you know what I mean?
Yeah.
And then you can go to them, to the source, and ask them. So yeah, it's incredibly useful. And I think the neurosurgeons that have a good grasp of it are going to advance a lot.
Yes. I think all this, our aim to improve ourselves for best outcome for our patient, to get best functional outcome by minimal invasive surgery like kyphoplasty, helping a lot of tumor patients, helping different age teachers, brothers have traumatic fall, RTA, fall in the football game, whatever. You just do a 1 centimeter punch, give him this bone cement, 2.5 or 3 ml of bone cement will help to restore the height of the vertebra and prevent us from long surgery duration, blood transfusion, a lot of pain, less hospital stay. This have human and economical decrease of the cost, and also the future, because sometimes we're operating same operation for tumor patients having a lot of pain, or a small football gamer, he can return to the work in next week. So this have a very wide spectrum. What I like about the junior doctors, they will start from this area as a challenge. You hear about it, you're going to learn how to do it, when to do it, what the complication, how to avoid this complication, with helping of the AI. This interest, I think we must suggest for John and Biam to arrange some AI special talk about programs and whatever. Every one of you
Believe
have
me.
a lot of clue and a lot of input.
Yeah, I'm trying, Mohammed, just to show, you see the chat GTP. Let's show Dr. Orkhan how we can explore the cementing. What should I type there, Mohammed? What do you want me to start with?
We deal with a couple of company. I will not advertise any one of them. I use a couple of bone cement, but it is the same technique.
What's
So,
a general question to start things off? Cementing what?
I can't get your point.
Oh, can you see my screen?
Yes, I see your screen.
What should I type in there into chat GTP to explore what you're talking about?
Okay. About cementing. Told him what's the advantage of cement kyphoplasty
Is the advantage
versus
cement?
open surgery or open fixation cage.
Cement. What's the advantage of
But
cement?
I understand, but why
What the
we are
advantage of cement kyphoplasty?
No, but we
Kyphoplasty?
what's the advantage?
Yes,
Why
kyphoplasty. H-O.
Sorry, but why we are asking? Why we are asking?
Saying?
Okay, H-O.
No, you write it right in first.
Kypho.
K-Y-P-H. Kypho. K-Y-P-H. You write it well in the first time.
Okay, kypho what?
Plasty. P-L-A-S-T.
Okay.
Advantage of cement kyphoplasty. That's it. Just let's see the answer.
Balloon kyphoplasty. And you could tell us, Doc, is that fairly accurate?
Fantastic.
Pretty well sums it up. It's a lot different than Google. And then what they'll do, Orkhan, at the end, they'll lead the conversation. Look at this. Would you like me to make a table comparing vertebroplasty versus kyphoplasty? And all I do is say yes. And it'll continue the conversation and ask leading questions that are relevant and that are intelligent.
Wow, awesome.
Yeah. That is such a good discussion. That's a big
double check the information.
So would you agree with that, Orkhan, what it wrote mostly? Okay, it says, would you like me to prepare a slide version of PowerPoint? Hell yeah.
Hell yeah, yes.
Okay, very good.
Very nice.
Okay, that just shows you. Okay, we'll be seeing a lot of that, and we thank you, Dr. Orkhan, for taking the time, especially because you kind of filled in at the last minute. I really appreciate it. And thanks for coming by, Mohammed and Payam.
Appreciate it.
And YM, thanks for participating. And we'll see you in the next Walter Dandy. Now, I always encourage the Walter Dandy people to do it every 2 weeks because it's more of a community. Once a month, well, it's like a hobby almost. But anyways, think about it, and we'll be communicating about you. Okay? Okay, everybody.
Definitely.
Thank you.
Thank you so much.
Thank you.
Dr.